We are going to go on to our next speaker, Dr. SUCHETA PARIJA, who is an additional professor and head of ophthalmology at All India Institute, AIMS Bhubaneswar. And she is going to show her case of complicated cataract. On to you, Dr. SUCHETA.
Yeah, good evening, madam. Can you see my screen?
Yeah.
So,
It's a dark screen. Yeah, you will click. No, it will come on. Yeah.
so yeah, just before I start my case, just I want to say this is a 36-year-old male who is a myopic and presented to us with a chronic uveitis. So this patient was a HLA negative spondylar arthropathy and has been receiving steroid for a long time. So 3 months we followed up this patient before taking up the case, and we saw there was no AC flare or cells before we proceeded. So 1 week before, we did a preoperative thorough examination, and we started the patient on steroid before we took up the case. The pupil was mid-dilated with multiple synechia. So what I did on the table is we started off. This thing is we did 2 side coats, and what I wanted to do is we wanted to do a synecholysis, take out all the synechia which is there. Sometimes these cases can have a broad synechia, and we have to be careful enough to remove it, or there can be epilenticular fibrosis which has to be taken out with a microforceps scissors. There is an alternative method. You can go and put under the iris multiple small bulks of this lignocaine or a BSS. But what happened, you can go about to do a pupilloplasty, but this we had done, but it did not stretch much. So we went ahead to put on the iris hooks in this cases. So I wanted to have a good capsulorhexis at least of 5 mm in this case. So better off you can use a forceps, because sometimes you can have multiple fibrosis in the anterior capsule. But I went ahead and got a good rhexis with the cystitome in this case. So having an adequate capsulorhexis is a very important thing in these cases. After that, we did a minimum hydrodissections in this so that the nucleus is free and you can rotate it freely. So after that, we went ahead and I wanted to do a stop and chop or a direct chop, but this case had a inconsistent nucleus. What sometimes it was a little bit harder, and otherwise it's quite a soft cataract. So my aim was to do a gutter and flip it up like a flip and chop method, but still I was not getting it. So slowly, what I was doing is I was trying to, with the low parameters, I was trying to take out or chop how much of the sections I can get so that I get a gutter. And what I wanted to do with take one end and flip it up. So this was what happening, and I was very slow with my maneuver because I didn't want any complications to arise at any point. So at each step, slowly moving about, taking a smaller piece, finally I was able to flip it up. So once I could flip it up, so this is how. Now I could flip it out, and once I have flipped it out, it was easier for me because there was not much of a thing. It was like a epinuclear bullous which came out. So I'm just stretching on this because sometimes we don't know how we get it. So be very careful what will be the PC at this positions. So after taking out or chopping out entire nucleus, you have to do a thorough cortical washup because no fibers we want to leave behind in uveitic cases, and do a good PC polishing. And here we put on a single piece hydrophobic acrylic inside the bag. So after this, we hydrated the wound, and there is a controversy whether you will be putting a suture because hypotony is something which has to be controlled. And this is the poster of day we had. The vision was quite good in these cases with 6-9. And what is important is we have to follow up these cases, and the regime of giving the prednisolone in this case has to be in a longer period, more than 6 weeks in these cases. And we used also diflupred in these cases and NSAIDs after for a prolonged period, and we are following up the case. Thank you.
Thank you. Thank you, Dr. Sucheta. A difficult case, but in a soft cataract, it sometimes makes sense to, I mean, it's very soft. You can just do a flip, or you can even do a stop and chop if you think you're not going to get your regular chops done, and you can get yourself out of that moment. And in these particular cases, flare, I think, is something which might stay even after 3 months, because it's an indication for some vascular incompetence. So would you all want to start the patient on oral steroids in a clear-cut case of uveitis patient, 2-3 days, unless there is more secondary causes? You know that the patient has a Behçet disease or some very significant uveitic case when you really need to keep them with the physician's opinion on the oral steroids and immunosuppressives. In a routine case, would you just start them on topical steroids a week before, or would you believe in starting them on oral steroids too?
I usually start only topical steroids. In straightforward cases, reasonably quiet eye, not much of inflammation. Post-op, you can always decide. This case, the post-op reaction was not much, but in some cases, you really do see a significant fibrinous reaction. A membrane forming across the pupil, sometimes a membrane on the surface of the IOL, which takes quite some time to break up. So intensive steroids, cycloplegics in the post-op period, very, very important.
Yes.
And along with that, if the reaction is very severe, we might even consider giving oral steroids.
Yes.
So I leave it to my uveitis consultant. So he actually gives it for quite little more number of patients who have had recurrent episodes, and then they have been on and off on steroids for some time. And one point during surgery was those fibrotic membranes in the pupillary margin. So if we nick it at the edge and then hold it and tangentially pull, they can be stripped off. If they can be stripped off very cleanly, sometimes it comes off fully, sometimes it may be in 2 or 3 pieces, but then it relieves the pupil of the binding down effect of the membrane, and you get a much dilated pupil with which we may not even need iris hooks or the expanding devices to be used for.